Hello everyone. Today is the talk about a newborn GI issues. This is going to be a long lecture. So if you're watching on Instagram, you have to log into the YouTube account to see the full video. Anyway, before further ado, let's start. So newborn GI issues, basically there are diseases and disorders. So I'm going to go in descending order. So we start with T fistula, then of course esophageal atresia, pyloric stenosis, perforation, necrotizing enterocolitis, malrotation, gastroschisis, omphalocele, meconium plug, meconium ileus, Hirschsprung disease, and imperforate anus. Of course, this is not an exhaustive list. Just to tell you briefly about these are the common problems which you should be aware of. So there are certain emergencies and there are certain non-urgent issues. So in non-urgent, you have GI reflux, colic, omphalocele, meconium ileus, and meconium plug. You can question that what about the last three? That could be urgent, but really it's not that urgent because, in omphalocele, the skin is intact. In meconium ileus, until unless it's not like an obstruction, and meconium plug, once the plug comes out, it's not an emergency. Basic emergency is necrotizing enterocolitis, abdominal perforation, malrotation with volvulus, T fistula, gastroschisis, atresia and stenosis, and Hirschsprung disease, and of course imperforate anus. So let's start with certain cases to learn together. So the first case is a 23-weeker, 5-day-old who developed abdominal distension. So 4 things we have to do: assessment, investigation, pathology, and management. So what do you think, what assessment you will do? Think about what investigation, what is the pathology of this condition, and what you would do. I'm not going to tell everything about that condition, just going through some x-rays. So anyway, assessment and investigations are done. So you can see the baby had a really shiny abdomen, and you can see air under the diaphragm on this AP view. And when we did the lateral film, you can see that air is accumulating over the intestinal content. So most likely this is, guess it what? Is it either spontaneous perforation or this is NEC? In real world, it's very difficult to really say. You have to wait for pathology, but most of the time, especially with this history, is only a 5-day-old, so most likely diagnosis would be spontaneous perforation rather than NEC. So 2 other cases. This is a preterm 24-weeker, now 4 weeks old, has some feeding intolerance. Look at the x-ray, it's very suspicious. The other case is a 27-weeker, 3-week-old with bloody stool. These are the classical symptoms where you are really worried about necrotizing enterocolitis. So what is necrotizing enterocolitis? The pathology is really difficult to understand, and there are a lot of factors that play in. But anyway, you have to know the modified Bell classification. So start with suspected neck, and then it goes down to advanced NEC. And you can read through the chart to see what things are. Basically, I want to go to the second slide to tell you a little way of remembering it. NEC is most of the time associated with bloody stool and nematosis. So staging is based on Bell criteria. So basically, Bell is baseline change, emesis and internal signs, low platelet, low bicarb, and leak, which is pneumoperitoneum. The thing to remember is it's a progressive disease. Please catch it earlier, and very high index of suspicion as we noticed in the previous cases. These are the 2 most commonly asked conditions, and I want to thank the Google Images for these images. So basically these are the 2 conditions. Please revise it. These are favorites, exam favorites, and the differences between the 2. Okay, now go to the another case. We have a case of a term infant who is 48 hours of age now. No stool has been documented, and abdominal showed patent anus with abdominal distension. Again, 4 things. What investigation you will do? What assessment will you do? Investigation. What is the pathology? What is the management? So this is the x-ray, and you can see the black arrow points out to a transitional zone. So this is most likely a Hirschsprung's disease. So another case, a 6-hour-old 34-weeker who developed bilious emesis with abdominal distension. What assessment you will do? What investigation? What is the pathology here? What is the management? So you see this x-ray, this is classic x-ray, and we call it like a cork screw or apple peel sign, which is classical of malrotation. And one has to, this is an emergency, especially you want to rule out if there is volvulus or not. So please be careful whenever a baby present early with bilious vomiting. The next one is a 1-day-old infant of diabetic mother who had delayed passage of meconium and some abdominal distension. Again, 4 things. Think about what are the possibilities. So here we did a study and we noted microcolon. Remember that microcolon and sometimes meconium is kind of present in the same way, but of course without the history of cystic fibrosis or anything in the baby, and especially with the history of infant of diabetic mother, you think of microcolon. Another case, a 7-day-old female preterm infant was receiving TPN via UVC is noted to have shiny abdomen. So this is the X-ray. On the left side, you see the baby's belly was really shiny, and the other one is post-op. This one unfortunately had, a catheter slipped out, and the UVC was in ductus, and patient was receiving TPN. So basically, TPN extravasated into the abdomen, and you can see on the X-ray on the right side that is total whiteout of the abdomen. But surgery was done appropriately, and baby did great. Another case, an infant underwent gastrostomy tube placement. Next day, he was noted to have abdominal distension. On the left side, you see free air as noted by the arrow, but on the right side, you see the whole abdomen is really white. So what is the diagnosis? Can you guess? Yes, that was a slipped gastrostomy tube. Not completely, but it was like partially dislodged. So when we did the study, the whole contrast went to the peritoneum, and baby did okay later on. So a few other causes of neonatal abdominal distension before we close. So see the X-ray 1, 2, and 3. What do you see in X-ray? Take a careful look, and all presented with abdominal distension. Case 1 presented with some feeding intolerance. Case 2 presented with some abdominal distension and crankiness. And third one was a post-op case for NEC, and this was done 14 days after the post-op. So take a guess, pause the slide, and I'll give you the answer. So first is inguinal hernia. Now go back and take a look. You see the air, and you can see the narrowing of the track here, which I'll show you here. The other one is scrotal hernia. You can see the air in the scrotum, and the third one was in a stricture. So I hope these all cases help you guys understand the problems better. Thank you again. I want to give credit to Google Images. All the images I use, which just for educational purposes, my residents, my nurses, my NNPs, and my surgical team for providing me such a great care with the cases. I hope this small presentation will help you understand the neonatal abdominal pathologies. Have a good day. Bye.